Great. Welcome back to the House Healthcare Committee on Thursday. With our continuing education process here, we now are going to turn to the Vermont Blueprint for Health. I think what we'll do, as we always do, are the committee introductions, and then we'll turn it over to John to introduce himself. And John, just so you know, we're pretty informal here on names, so hopefully that's okay. But Art, do you want to start?
Yeah, sure. Art Peterson from Clarendon. I represent Clarendon, Wallingford, West Rutland, and Rutland Town.
Yeah, Leslie Goldman, Wyndham, Rockingham, Brookline, and Westminster.
Casey Rebecca, I represent Winooski.
Laurie Cordes, Lincoln, Bristol, Moncton, and Starksboro. Also a nurse.
Dr. McFawn, I represent Barrytown and a part of Williamstown.
Lori Houghton, City of Essex Junction.
Alyssa Black, Northern Essex.
Alan DeMar, represent Enosburg and Montgomery.
Joe Andriana, I live in Orwell, represent Shoreham, Whiting, Sudbury, and Hubbardton as well.
And we have one committee member on screen.
Right behind you, my name's Bobby Farley's Rubio, and I represent Barnet, Reigate, and Waterford, Caledonia 1.
Great. We'll turn it over to you.
Well, thank you, Lori. I will try to be on a first name basis, though I may.
Whatever you are comfortable with.
Refer to me by my first name. I'm John Soroyan. I'm the Blueprint for Health Executive Director. I started January 3rd, 2022. Just briefly about myself, and if you'd like to learn more, there's plenty online, but I'm a board certified pediatrician. My approximately first 10 years of my career was spent at Columbia University on faculty. I served children and families with serious illness and pain on the faculty there as a palliative care pediatrician and pain management physician. And in 2013, I made the move from the city to the Upper Valley. I live in Norwich, Vermont, to become the medical director and then the regional medical director for hospice for Beata Home Healthcare in New Hampshire and Vermont. And my career has taken me now into state government and in the role of executive director of Blueprint for Health. It's an honor to present to you all today, and certainly thank you all very much for your service now and throughout your careers. I will share my screen and begin with my slides, and I'll orient you all to some of the materials that I've shared with Claire. Thank you, Claire, for taking it. Were you able to get the switch slides? Great, thanks. This morning I made some last hour changes. Should I just reflect what we spoke about, Lori, about?
Okay.
Yeah. So I'll do one thing at a time. It's so nice not to be, sorry, I'm just gonna, so nice not to be on Zoom, but to be in person. Am I good to go in terms of the image behind me?
You are good.
Okay. If someone has something they'd like to ask, just please ask it as I'm speaking. I have prepared remarks that I will read. And I will be able to kind of go in and out of them as able. In addition, you should have available to you in PDF format a glossary of key terms which expand beyond the Blueprint for Health. And I tried to put them in language that was as straightforward as possible, but still reflected detail. And for those of you who are inclined, there's extensive references at the back for you to check our references. I will refer to the other document that I included for you all as we go. Thank you, Madam Chair, for inviting me to present to your committee this morning. I am very honored to be here and have been looking forward to this presentation for some time. The statutory framework for the Blueprint for Health was established in 2010 through Act 128. The Blueprint has 15 years of experience as to how healthcare is distributed statewide. Through research, design, and implementation of innovative healthcare delivery and payment models, the Blueprint remains a multi-payer, whole population program that can develop and test healthcare reform initiatives, multi-payer, commercial insurance, Medicaid, Medicare, whole population, everyone is served. As an innovation engine, it has implemented concrete and durable changes to treatment delivery, payment models, and healthcare information systems, particularly related to integrated primary and community care. The Blueprint for Health is ambitious in its goals for Vermont's primary care providers to be supported in taking a long-term, whole-person approach to care, one that addresses medical, social, mental health needs, and provides access to a range of supportive services in an integrated fashion. For primary care providers, the Blueprint for Health can encourage an expanded focus on the needs for the entire population they serve. The program has offered support through delivery system reform and payment models that give primary care the ability to invest time and resources in team-based, data-driven, quality-focused care. And I'll be going into all the details of which each of those things mean, I hope, in a easily understandable way. Well, I'm going to jump right to return on investment. I'm not necessarily a financial person, but I did want to bring up the work that has been done by my predecessors from the beginning. This is a handout that's available to all of you as a PDF. Ina Bacchus, the Director of Healthcare Reform, referred to the Multi-Payer Advanced Primary Care Practice Demonstration report, I believe 2 days ago in her presentation to you. And I do want to draw your attention to the return on the dollar or the return on investment that has been shown for Medicare recipients in the past through Blueprint for Health, as well as, good morning, as well as the work that the Blueprint itself has done over the 2013 to 2017 years, and that's quite detailed here. I did not detail it in my presentation, showing return on investment based on money spent. So I am going to move on, but I do want to bring that to your attention in terms of evidence as we go forward, perhaps to my next presentation. The Blueprint Executive Committee is defined in statute by the members representing departments at the Agency of Human Services, including the Department of Health, the Department of Mental Health, Department of Vermont Health Access, as well as representative from the Green Mountain Care Board. 2 private health insurers are represented, healthcare professionals who provide services are represented, as well as healthcare associations and 1 consumer. Representative Houghton is an individual appointed jointly by the President Pro Tem of the Senate and Speaker of the House of Representatives, and we are honored and very excited to have her join as of the middle of last year. Health service areas is a term that I've defined in the Blueprint Glossary for Terms. It's not an intuitive term that I would expect people to know. It derives from Department of Health's hospital service area term and has been modified mostly for convenience of administration for the distribution of funds. So please, as I go through and speak about health service areas, if you're curious about knowing the derivation of that term and how it came about, I certainly gave you that. But that is a term that you'll be hearing me say. I'll try not to say HSAs, but I will try to use the term health service area, and the map with our specific leaders in the program are behind me. So they represent areas in which patients receive their health care and historically have been defined by which hospital they've been discharged from. Again, just to give you all a little background on why we still use that term. Blueprint utilizes the health service area to help ensure that resources are distributed across the state in a way that is accessible to most people and is shown here. Last year, I completed a all health service area visit myself with my team. There was only one I was not able to visit because of COVID, but I visited all of our health service areas last year.
Leslie?
Leslie, sorry.
I'm sorry, but what about discharges from Dartmouth? How does that fit in?
Could you specifically tell me more, Leslie, what you mean in terms of what happens to them?
Well, if you're thinking about discharges from Vermont hospitals and the care they get, I'm just wondering if someone that lives in Saxon's River, but is discharged from Dartmouth, how do they get services?
Well, in an example that a person's primary care provider was in Vermont, if that were a Blueprint for Health practice, they would serve all the things I'm going to talk about in terms of coordinating care and following care if they had a hospitalization or a specialty visit at Dartmouth Health.
Yeah, that's the new. Okay, thank you. So they'd have to have be in a primary care practice in Vermont.
Correct,
Got it.
right, and be a Vermonter.
Yeah.
Each administrative entity, also a term that I developed, the glossary of terms, and I do want to pause now because you're going to hear that term frequently, and it's not an intuitive term. So the administrative entity is the primary financing and management entity for Blueprint community health teams. So each administrative entity hires a Blueprint program manager to oversee Blueprint activities in that health service area. The program manager will be the primary local contact responsible for management of all programmatic and administrative components of the agreement. So the Blueprint for Health centrally enters into a grant agreement with that administrative entity every year. That's the arrangement. They provide support and help in the development of effective strategies in alignment with the grant and what the program is expected to deliver. They establish key relationships with the practices, and I'll go on to define why those are called patient-centered medical homes. In addition, community partners already in existence that serve their communities, and then governmental agencies and regulators. The Blueprint program manager is a key liaison for our central office trainings, the strategic direction that I set with our executive committee, coordination and support in developing and spreading best practices. I'm going to be reviewing 4 components of our Blueprint programs in more detail, and this is an oversight side for all of you to kind of show you what's coming. So firstly is patient-centered medical homes and quality improvement facilitation. Again, terms many people are not familiar with that I want to make sure you have an understanding of today. Community health teams, a term actually sometimes people have heard. The hub and spoke system for opioid use disorder treatment, a term, the hubs, the spokes, sometimes something people are more familiar with, as well as the pregnancy intention initiative. So I am going to try to get through all of these, but please do stop me if something is not clear, and I will love to entertain your questions at any point. So at the center, and I'm going to spend some time on this slide just reading some prepared remarks, so please be patient with me. The Blueprint was founded on the establishment of patient-centered medical home recognition by the National Committee of Quality for Quality Assurance. Practices that meet these standards have been shown to help better manage chronic conditions, improve quality, and are associated with lower healthcare costs. The Blueprint supports practices that become recognized in this manner through additional payments to support their work. They still do their regular billing, what we call fee for service. These are additional supplemental payments. The practice and practitioners know their patients. They understand their health history. That's the expectation they're held to. And they take these preferences into consideration around prevention activities for existing conditions as well as new conditions. There's expanded access to the provider and care team through electronic communication, extended hours and after hours coverage, and screening procedures are done regularly based on the patient's age and gender. There is assistance with managing various specialty referrals, referral follow-up, care planning, and care coordination, similar to the question that Representative Goldman was asking. What if they go outside the borders of our state? Maybe not just to Dartmouth-Hitchcock, but for example, in Bennington, Albany Medical Center, or sometimes even up north to Plattsburgh. Altogether, it's an approach to care that emphasizes and supports informed decision-making, motivational interviewing, patient-centered goal setting, and self-management of chronic conditions. The Blueprint also supports these medical homes, these patient-centered medical homes, by providing each with a quality improvement facilitator that you'll see on my slide on the screen. This is a professional who uses evidence-based tools to help the practice meet the quality metrics of recognition, as well as help them attain their own goals for their practice and their population.
We have one question.
Yes, please.
I guess I'm lost as to what a patient-centered medical home is. What are we talking about? A hospital, a doctor's office, or somebody's actual home? Or all three?
Sure. It's not someone's home. And the office setting may be based in a hospital. It may be based in a private practice. It may be based in a federally qualified health center. And it's a distinction. So it's a term that was developed first in pediatrics and then in family medicine. So it's not a home. It's a home in the more metaphorical sense of that's where people always come back.
Right. Okay. So it's a facility.
A physical place.
It's a doctor's office. Your primary care physician's office.
Oh, okay. Yeah, that's all.
Yes.
And this is a special distinction that they get by meeting
Okay.
standards.
Yeah. No, I've got it.
Yep.
Thank you.
I didn't use the home for my graphic. I went with the circle because I felt like the home might be a little confusing. That was a debate on my way to work this morning. So I went back to the circle.
As an add-on to that, is it a four walls sort of thing, or can they have like the equivalent of DCOs or MOUs with other practitioners who can be part of the medical home?
Help me with DCOs and MOUs, like maybe give me an example.
So does a medical home have to be within four walls, or can you have a primary care provider and then have a specialty care provider who is at a different location but also part of the same medical home?
It does have to be a physical site inside Vermont. I don't think there are any telehealth only primary care providers that are Blueprint practices currently. I don't know if that's your question. And in terms of specialists who might be affiliated through an agreement with the practice that might come and go or consult, I do imagine those relationships exist, but I'm hard pressed to, I wouldn't put any restrictions on someone if someone wanted to contract, for example, with another provider. They could, if that's the decision of the organization, that to my knowledge would not interfere with their ability to participate in our program. The variety and the flexibility that programs enjoy, I believe allows for that. But like I said, I'm hard pressed to come up with an example right now of a practice that might do that. Yes.
So coming at it from the point of view of a patient, the patient it goes to their primary care provider or is seen by their primary care provider at the patient PCMH, the medical home. And part of the Blueprint for Health includes other team members that will help that patient, for example, with a chronic illness, that the primary care provider either doesn't have the time for, or I'm not putting this in the right way, but there are other healthcare professionals who have the skills to help this patient.
I can dig into that a little bit now if you'd like.
I think it might help.
Absolutely. So if the practice is recognized as a patient-centered medical home, the patient receives care, hopefully over the long term, in a practice that meets stringent quality national guidelines. So practices that meet these standards have been shown to help patients with managed chronic conditions better, to improve quality. And the Blueprint practices allow that expansion of the interaction between the provider to go beyond it into other avenues of care based on what that person needs and wants. So these supplemental funds allow for that extra layer of support to the individual beyond what a more traditional, this is my assessment, here's your problem, here's your prescription, whatever it may be, see you in X number of weeks.
So it might involve a social worker, it might involve a nutritional expert.
That's in my next slide where I get to some of that, but just to stay with the patient-centered medical home, because you're right, I think we should stay here for just a bit longer. It also includes the patient involving having certain screenings on a regular basis based on who they are and what, how old they are, what they need. And those would become available in a patient-centered medical home above and beyond the medical care. And I think I should go to the community health teams next because you gave me a nice
So I just want to clarify
course.
something, and then Joe has a question, and then
Sure.
we want to make sure that we do get through these slides. as a patient, if my primary care provider is a patient-centered medical home, right, and I go into the doctor's, I don't necessarily know that it's part of the blueprint. I just know that if I go into my primary care and through that discussion, she determines and I agree I should see a social worker, they might have a social worker in that facility because of this funding and this designation. They don't say to me, oh, well, you're part of Blueprint, so therefore we're going to be able to give you the social worker. It just is part of the care that I receive in my doctor's office. Is that a safe assessment?
Yes, it's very unusual for a patient and staff members to know that. I shouldn't say very unusual. I'm surprised when a staff member actually, and it happens, but knows that part of their ability to serve and be employed comes from Blueprint dollars. I don't know about before I joined, but that our mission isn't to tell people that this money is serving you. It's really for people to feel taken care of where they go for care so that it's integrated into the people they trust. Most families, parents, individuals develop trust with the provider that they see. And if the provider is guiding them, then the provider's guiding them. Payment mechanisms and those sorts of things, in my opinion, should hopefully be in the background. Though for curious people, we have an open website and open meetings, so people can learn all they want about the Blueprint. But it's unusual for individuals to know, I think, to your point, that it's funded by the Blueprint.
Right. All right, Joe, and then we'll move on.
Yeah, of course.
Okay, great. Then move on.
Okay. So I've said now a second time that I wasn't gonna. It's not a strong area of mine, but I am going to talk about payment because it's important, and you all are very important in this. The PCMH, or patient-centered medical home payments, that the committee sees on the left side of the screen represent the current per member per month amount paid by commercial insurers, Medicare, and Medicaid. I want to repeat, these are supplemental additional payments to what the practice would already bill for those visits. These are funds that come in to the practice on a monthly basis based on the numbers that are attributed to those different types of payers. The commercial and Medicaid payments have remained the same since 2016. The Medicaid payment, you may be wondering, is higher than the commercial payment because of a historical, and again, this is technical, but I'm going to say it anyways, because of a pre-existing payment for managed care services. The Medicare amount is, and again, this is I have to slow down to understand these things too, is based on available shared savings from the all-payer model agreement, and that is lower, as you can see from the others. Half of the performance payment is based on healthcare utilization of the patient population, and that's up to 25%. So there is a, one might call an incentive, or it's quite modest, but for meeting certain cost utilization goals. And then the other half is based on population healthcare quality measures. So this is a lot to take in, especially with all that you are hearing, but it's a very important slide to know where these amounts fall right now.
Do all commercial payers pay into this?
The three commercial insurers, thank you for the question. The three commercial insurers that participate in the state of Vermont are Blue Cross Blue Shield of Vermont, MVP, and Cigna. And I included this in the glossary because this is a definition that I have to go back to as well. The fully insured plans are who participates in the blueprints, and this gets into language that I struggle to define too. If a company is paying their own claims and is not actually holding insurance, they are not obligated to contribute to the blueprint. And there's technical names for that group that I included in the glossary. If an insurance company is out of state, or if an insurance company is, well, certainly Veterans Administration, Indian Health Services, those types of payers don't participate in the blueprint. So it gets into a really important part of the discussion that I tried to supplement in the glossary, but I'm happy to talk about.
I just think that it's really important that the committee understands, because we'll be making decisions about other things, that, like the self-insureds do not pay in, but every patient in that practice, regardless of who their insurance is, benefits from the services that are being provided, from the funding from the blueprint. So I think it's important to realize only a few are paying in, everybody benefits.
And so they're a per member per month.
They don't receive a per member per month. They still reap the benefits of the services.
Joe, did you have?
Answer my question.
Okay.
Representative Peterson?
How do I frame this so I can understand? This fee is paid by the insurers on the folks they insure to you folks? To Blueprint?
Yeah, I can help you with that and explain. I think I understand what you're asking.
Well, I'm just asking if these amounts are being paid to Blueprint.
No, they go directly to the practices. They don't.
They go to the
state.
practices?
Yep.
Okay.
Mm-hmm. We direct them.
You direct them?
We do. My team does, yes.
Okay, and so do all practices have to be part of this?
It's voluntary.
It's voluntary, so a XYZ medical can decide to do this, and then every member they have falls into these categories. And the insurers pay the practice, and then they get the care.
They get the care anyways, but yes, they would get the additional standards applied to them. And
okay, and this buys them what?
I'll go into that more, but I'll just say
right.
now.
Yeah. I'm just trying to understand.
Sure, I have actually a slide to sort of give
Okay.
you an example. I think it's next.
We'll get there.
All right.
No, please, no, it's excellent. So this is why I created this slide. So in a small practice, and this is just an example. This is not a actual practice in Vermont. This is me coming up with a small practice of, let's say, 2 to 3,
Sure.
maybe 2 physicians, 1 nurse practitioner. If Zoom doesn't let me see my own slide in total. So this is an example of how the numbers would fall together to deliver additional supplemental dollars on a monthly basis to the practice that you were just describing that had chosen to participate. And the practice has the latitude to spend those dollars as they see fit to maintain those high quality standards that are done yearly. So this is an example. If and I'm going to call this a smaller practice. I hope that's okay. It's not a solo practice, but a smaller practice. If there were 2,300 people of their patients who were insured in the ways we've been talking about, the wholly insured through Cigna, Blue Cross Blue Shield, MVP, Medicaid, and Medicare, that dollar amount would be calculated based on the base payment rate that I reviewed before, $3 for the commercials, $465 for Medicaid, $205 for Medicare. The performance payments are calculated every year and then paid out at that amount. And that's an example of how much additional income would come. This slide.
So when you think about,
And to Alyssa's point, so the per member per month was applied here to Cigna, those 5 payers. But let's say I have employment through, healthcare through my employer. That is not one of those. The practice does not receive a per member per month payment for me. But if I have needs, I'm going to be serviced by this team. Go ahead.
However, you said a moment ago that the quality standards wouldn't apply to that person.
Yes.
And so
It applies to the
they
practice.
would.
Yeah, they
So-
receive the benefits of them. Absolutely.
So, would the quality standards of Blueprint, or I guess just right
NCQA,
do these quality standards apply to the practice as a whole, or do they apply to the population that is in a insurance that is paying into Blueprint?
I was answering the first part of your question and I didn't listen as well as I should have to the last. What was the last part?
Basically, it's just, do these quality standards apply to the provider population as a whole inside that provider, or do they just apply to the subset of those inside that provider population that are part of a plan that goes?
There's no subset.
Okay, no subset.
There's no subset.
Great, thanks.
So when you think about it from a yearly point of view, if you get $7,000 a month, that's like $70,000 or $80,000, which is to pay for staff. And so you're going to be able, as a practice, really expand your thinking about how you might get a social worker, you might get a dietitian, you might get whatever that you think your practice needs. So no, she's shaking her head.
No, I'm not shaking my head.
Oh, okay. Well, that's my understanding. Is that correct?
Yes.
Yes, as he said, you can use the money, the practice can use the money as they see fit to
Yeah.
meet those quality standards.
So that's significant money, I guess, is what I'm looking at. I'm saying that has meaning.
Yeah. And I'm not going to deviate myself too much. I will get to my next slide. New York State has an extensive patient-centered medical home program based on the same national body, NCQA. Their legislature, may I share this? Is that okay?
Sure.
Invests approximately $200 million per year into their patient-centered medical home program that is paid from the Medicaid budget. And Joe, just to get back to your point, and I just spoke with them a few weeks ago. It's really fun to speak to neighboring states. I'm sure you all do the same thing, but their dollars to maintain those standards serves the whole population. So there's no, I don't even want to say it out loud, that it serves the whole population. The payments are based on the Medicaid patients in the practices, but the benefits of that standard are for everybody. So just in terms of our neighboring state, just to share that with you all, the perspective. I should probably move on, but
Yeah.
I'm happy to keep going too.
Let's move on.
Topic? Okay. My slide isn't advancing, so let's see. Should I stop share and then restart maybe?
Yeah.
I probably just touched the wrong button or something like that. This is so much better than being at home looking at the walls. So from current slide. Okay. Community health teams. So I started and we spent time, rightfully so, on that darker green inner circle. And I'm going to expand out now to our community health teams, which also receive funding, which I will review in detail in a similar manner, but for different things. So community health teams supplement the services available in that medical home and link patients with social and economic services that make healthy living possible for all Vermonters. The community health team staff is intended to provide supports and services that are not generally covered by insurance at no cost to the patient and with no regard to insurance status. These staff may include social workers, care coordinators, mental health counselors, dietitians, community health workers, and other professionals who provide and support whole person care. The community health team is intended to provide supports and services that are not generally covered by insurance. None of these individuals, for their time with the Blueprint, are billing for those services. And it's at no cost. I'm just repeating myself, but I think it's important. It's at no cost to the patient and it's without regard to insurance status. And there's a multitude of examples that I could give you, but I'll just pause there to see if there are any questions.
Who employs the community health teams?
Great question. I think I have a whole slide on my payment slide that goes through the different means by which they can be funded. So I think I'll take that question. And the Blueprint does not, the state does not. But that's a great question, and I'll go through it on my payment slide. Yes, Joe.
Topper, did you want to go?
Thank you. Did you just say that the patient pays nothing?
For community health team members, if they're at a practice that's has received this distinction and their provider or the care team determines with them that a member of this resource for the community would be helpful to them, and the person agrees, they are not billed, there's no copay collected, they meet the community health team worker and they connect. Yeah, Vermont's ahead. Vermont's way ahead. This is the envy of our 49 other states, because and I brought this up with New York too, they have patient-centered medical homes in many other states. The synergy between community health teams and patient-centered medical homes is very unique to us. Rhode Island's trying to copy it, I think now I can say that, and I think Maine has too. But we are very unique among states to offer the community health team services in addition to the standards of the medical home.
Joe, did you have a question?
I did. What does this look like to the patient? So from the patient's perspective, are you in with your doctor and your doctor says, hey, I'd like you to go to this nutrition specialist, or I think it'd be helpful if you spoke to the social worker. And so basically the primary care physician is sort of the conduit by which they access the community health team, or does the patient have to go seek out the community health team?
The office staff, the provider would determine that with the person. And the location of the community health team member may be a nutritionist who does appointments by telehealth. It may be a counselor who's right there on site. It might be in some of our communities, the community health team has the ability to meet the person where they are. They go meet them at their house or at their, I've heard all sorts of examples. They just go meet them. So there is a lot of flexibility in terms of what's implemented and how it's implemented. And I would, again, there are some communities that I visited where there's a label of community health team, like when you walk up to the third floor or the offices. Some people call it the community help team. They don't call it the community health team. They call it the community help team because when there's an issue that people just can't figure out in those initial minutes, they turn the question to the community health team to try to figure out together and really put their minds together. I'm going to say that one of the key functions of the community health team is to serve as an access point. So just to build on what Representative Andriano said, if the decision to work with the community health team is made by the staff and the provider, the community health team member also then would make a decision with that individual. May I connect you with food services, with housing supports, with transportation services, with specialty care that can be coordinated at the medical home, and many other different already existing, not funded by the Blueprint, different types of services that exist. So that's why I designed these 3 slides sort of in concentric circle fashion.
I think we can keep going.
Payments. The Blueprint supports the staffing of the community health team, or to be, I guess, more technically correct, directs the staffing of the community health team by directing the public and private health insurers to make payments to the administrative entity. So this is different from the direct payments for being a medical home that go to the practices. These are quarterly payments that go to that administrative entity, also one of the terms I defined at the beginning of our time together, for that region of the state. Mostly that's the local hospital, but in some of our regions, it's the federally qualified health center, like for example, in Lamoille. Blueprint funded program managers oversee the outflow of those funds to make sure that the needs of the community are being met and that practices have the appropriate level of support. So the program managers have to work out what type of community health team member, how much time with all the different practices in their health service area. They have to work that out. Medicare funding availability, as you can see, has not kept up with the past payment increases of both commercial and Medicaid. Yes, Representative. Do you have a question?
Yes, I didn't. You looking at me?
Yeah.
Yeah, I didn't have my hand up, but you could tell that I had a question. So there's two revenue streams, one that goes directly to the primary care practice on a per member per month basis. And then there's another funding stream that goes to the community health team from one of these administrative entities.
That's two of the revenue streams that we oversee. Yes, that's two among several. Yes.
And the revenue stream from the administrative entity to the community health team pays the salaries for the community health team, for the social workers, the dietitians, or is it a mix?
I think to answer that part of your question, it varies. The dollar amounts don't cover the full salary and benefits of every person up to their full amount. Many of the administrative entities and practices contribute to those individuals' salary on top of the dollars that are matched to them from their administrative entity through community health team. And I do want to get to your question on this slide, the staffing models, and make sure we cover that. Did that get it, what you were asking?
Yep, thank you.
Okay, sure.
Do I just clarify what
Of course.
you said?
Yeah, no, maybe I said something wrong. Go ahead.
No, I think you said something right. I just want to clarify more. So you're saying that the money that the health service area community health team administrator receives from the commercial Medicaid, Medicare does not cover the cost of what it costs to employ the community health team members, and they are then employing them themselves as well?
It really varies, and I don't have clear lucidity into the finances of all these administrative entities, as you might imagine. What I hear is that in different parts of the state, John, the dollars we get for 0.8 of this individual who has this expertise from your directed funding, which we love and we want to keep, does not meet what we need to pay someone. That's an example of what I might hear as I'm visiting health service areas. The degree to which that happens in different communities, I don't know. There could be other communities where the dollar amounts match and they pay that person's salary and benefits with the amount distributed. I don't have insight into all the details, but you're right, it does vary.
And so do you mind me stepping in?
No.
So, and that is the choice of the practice. If they want to offer more services than the money pays for.
Oh, the negotiation of what the salary is?
No, the services that are available.
Those are joint decisions made with the local program manager to figure out what's a priority to them, what's a priority to their population, who's hireable in the community.
I guess my point is it's not the blueprint saying you must offer all of this, but we're not,
Okay, I hear what you're saying.
paying for all of it.
We set the guidelines and they make the decisions based on their own finances and what they receive.
Yeah, I always think of it as the old Wheel of Fortune, where you get a pot and you're like, I'll take that Barcalounger for $277 and I'll take that for.
No, that was that.
Oh, I'm not. That was the old Wheel of Fortune when you'd go shopping after you won.
Yeah.
I'm
Art,
sorry.
okay, I'm going to say Art, and do you have a question?
I do.
Okay, you hardly ever have questions. So after Art, we're going to Alan, and then we're going to continue with the slides.
Okay, yeah, and I know we're in time limit here, but community health team, who are they? Are they the small circles in the green circles?
Mm-hmm.
Okay, that's what I need to know. Now, so not only are they paying the provider, the medical home people, but then also paying them.
Yeah.
Okay, well, when you said earlier that these are all free, well, it ain't free. All this money is gonna come back in premiums to me. I think.
Premium from the insurance company.
Pardon me?
Premiums from the insurance.
Yeah, correct.
company.
I mean, to say it's free is okay, and I get it, and I'm not necessarily against it, but this isn't free. I mean,
As my husband would say,
a
nothing.
lot of money
is-
changing hands here.
Yeah.
Yeah, okay.
What's the caseload of a typical manager?
Oh, wow. Great question. It's a really good question. I spend a fair amount of time with my staff asking. Just to start with one example, so in the northern part of our state, in Chittenden, and I cannot speak for UVM Health Network, but in collegial conversations, for a certain type of clinician, and I'm gonna have to rely on my memory here because I don't have the emails or the conversation notes in front of me, an individual who's providing a variety of counseling services. And then again, this is my memory. Caseloads, I think that they were aiming for was between 80 and 100 for one full-time person. The programs that the Blueprint oversees that are at the end of my presentation, caseloads can be around 50. It is, I'm just going to reflect anecdotally for you all as I toured the state, which was amazing, and met community health team members. It was common, I'd say, through maybe 3 or 4 of my visits for a social worker to say, John, there could be 3 of me. Mm. And for a nurse case manager to say, John, there could be 2 of me, and I'd still be trying to keep up with my work. And I didn't prime them. I mean, certainly they knew I was coming, but I don't think one person answering in one part of the state knew what I had heard, 2.5 hours away. So they're in it and they're meeting the needs. But like so many in the healthcare system, they're feeling stretched too.
All right, let's keep going and we'll try to get.
So on the right side of this slide is that an administrative entity can hire the staff and deploy them to the community. They can contract with a local provider such as the DA so that the money would be what the term I use is pass through, or they can actually fund that medical home to hire their own staff. Just to get back to your question, that's how I summarize it 3 ways. If there are other ways that people are doing it out there, I probably need to catch up. So similar to the example I presented to the committee for patient-centered medical home payments, this slide depicts funding to one administrative entity paid on an attributed population of 12,866 individuals. So in this example, the every 3-month payments for community health team fund of money would go to the administrative entity as follows. Cigna, Blue Cross Blue Shield, MVP are the commercial insurers contributing at $277 per member per month, and Medicaid also at $277 and Medicare at $253. And again, this is an example, but for an attributed patient population, that could mean that on a quarterly basis, that administrative entity receives a little under $110,000 that they, with their program managers in the practice, has to then figure out how to spend. In addition to community health teams, there are 2 additional key programs sponsored by the Blueprint that patients may interact with in medical homes. The Hub and Spoke is Vermont's system of treatment for opioid use disorder. Joe?
Just clarification.
Yes.
I'm
sorry. Yeah, sure.
It says quarterly at the top and monthly at the bottom.
Oh, did I make a mistake?
If it was quarterly or monthly.
I might just have a typo in my slide, Joe. 1 sec. I'm not going to go reverse because that seemed to upset the machine. But let me that just might be a typo on my part. Community health team payments are quarterly.
Great. Okay.
I'll correct that slide before tomorrow.
Whoa, that's a shit ton of.
Where did you see it?
It is on slide 16. It says monthly.
Oh, great. Thank you. Yeah, no, we'll correct that. Thank you. Yeah, thank you.
Well, the payments are quarterly, but the slide is the monthly amount.
Yeah.
It should say quarterly at the bottom. Just typo. All right, let me just reorient to where I am here.
The payments are monthly, that's what's.
Okay, we're going to move on.
Thank you.
Thank you.
At over 75 spokes, doctors, nurses, and counselors offer ongoing treatment of opioid use disorder that's fully integrated into general healthcare and wellness services. And this framework utilizes the medication for opioid use disorder for treatment and efficiently deploys that expertise through movement between our hubs and our spokes to expand access to opioid use disorder for treatment of Vermonters. And in this slide, You can see where the hubs are located. So that's for the high need daily type of visit for a person with medication opioid use disorder. And on the right, I just show you the growth of the program in terms of persons served, the number of prescribers, and the number of additional staff hired from 2013 up till Q2 of last year. The Pregnancy Intention Initiative helps ensure that women's health providers, patient-centered medical homes, and community providers build thriving families. In 2017, the Pregnancy Intention Initiative, also called Women's Health Initiative, or WHI, a name that we're moving away from and are going to change, was begun in an effort to increase the intended pregnancy rate. As of 2020, the intended pregnancy rate in Vermont was 57.1%, which is an increase from 55.9% in 2018. On the slide are multiple components, including the comprehensive family planning counseling, the psychosocial screening, intervention, and then help getting to services if they're needed. And I'll just define the question, would you like to become pregnant in the next year? And providing counseling is one of the cornerstones of the program offered for persons who may become pregnant. As of 2022, attributed patients to this program were 22,000. So that would bring in $1.25 per person per month, and support for staffing either through the community health team or through actually specialty practices like OB-GYN receive the staffing in addition. So in the OB-GYN practices, they receive funds to hire a mental health clinician. In the medical homes, the community health team is brought in to serve that counseling role. Through the Pregnancy Intention Initiative, people who can become pregnant receive substantial preventive services, either in the women's health setting or OB-GYN. And through the Pregnancy Intention Initiative, women's health specialty providers provide enhanced health and psychosocial screening with timely access to long-acting reversible contraception, which is also paid for at a one-time payment. New staff training and payments support effective follow-up, provider screenings through brief in-office intervention, and referral to services for mental health, substance use, trauma, partner violence, food, and housing. I have some resources on my slide, as well as for your perusal later, some history of the blueprint, as well as distribution of our patient-centered medical homes. Should I stop my share now and let you open discussion? Thank you, everyone.
And Leslie has a question, but I'm going to go first. What percentage of our primary care providers' facilities, so not individual providers, are part of the blueprint?
Over 70% of Vermonters can be considered being part of a blueprint practice. And while the numbers vary from year to year, and by the time I come back to present to you all, I should have a very concrete list of around 165, 70 primary care practices in Vermont. Over 130 of them are affiliated with the blueprint. So in terms of population, covering 70% of the population, that actually, we were surprised to hear that's what New York State's is as well. They're at 70%. So we're at 70%, but we were first. And that's that. I will have more detailed information. We're actually collecting that.
Okay. And I'm just, before you go, I just also want to, John's talking about coming back, which he will be, because part of Act 167, which we'll walk through with Ledge Council next week, which we passed last year, there is a section that requires the Blueprint for Health to come back with a report. We'll have it tomorrow or next week. To make recommendations on the amounts by which I'm just going to read it. The amounts by which health insurers and Vermont Medicaid should increase the amount of the per person per month payments they make towards the share costs of operating the Blueprint. And there's more language and we'll walk through it. But this was really important work of the committee last year. This is an important program, as it has been outlined. It has been in Vermont for a very long time. And so we'll be looking at that report, have John come back in, go through the report with us, and then, determine what we want to do with the recommendations. Leslie?
So as someone who's spent decades working in primary care, this is amazing, right? To have the kind of supports that are needed because, you know, I might spend 2 hours a year with a person, but underneath that, my work is all this work. And that's really excellent.
Yeah.
So I'm wondering, what's next for you? What's next for the Blueprint as you you seem pretty established, it's embedded. What's coming next? Or are you just are you spreading this or, you know, sort of how do you imagine moving forward?
The work that we've done in the last 7 months for how to move forward has been the focus on our directive from Act 167 and to develop for you all a thoughtful and considerate response to that, which I'm not going to go into more detail about right now, but that's very much where our work and thinking has been, is on the directive we received in Act 167 as Chair Houghton.
So we'll be taking it up.
Okay, thank you.
Any other questions? I will say, I've been in this committee 6 years and Maury, I think 4, right? Or anyway, this has been the most comprehensive presentation we've had on Blueprint. And so it's extremely helpful. You know, I will say, especially until I joined the executive committee, it was like this word that everyone, you know, used, Blueprint, and I had no idea what it meant. So this has been extremely helpful. And I just want to also say, I had an opportunity to visit FQHC over the summer, and they have a community health team associated with them. So I encourage you to reach out within your community to an FQHC or your own primary care provider and say, hey, are you connected to the Blueprint, and see how it works for them. You know, it's pretty amazing, some of the benefits that they can provide people. So, thank you very much.
You're welcome.
We look forward to seeing you again soon.
Likewise, thank you all.
Thank you. And we're done until 1 o'clock, so